Testing, testing. Ready? Ready? Oh, yeah, ready. Okay, good morning. It's still morning, right? Good morning. Good morning. Good morning. That's better. My name is Soyeon Shim. I'm the director of the John and Doris Norton School of Family and Consumer Sciences. And on behalf of our faculty and staff and our students, I want to thank you and welcome all of you to our third annual Back to School lecture for our alumni and friends. And during the past homecoming weekend, since we're moving to our new building, we thought it would be fun to give a back-to-school lecture experience for our alumni. Isn't that comfortable, sitting in the chair? Just move around. Can you turn around and say hello to your next neighbor? Turn around. So you can move around your chair. See, the classroom is designed to give our students maximum flexibility for discussion and brainstorming and creative ideas, and for faculty members going around and talk to students from anywhere, everywhere. And this classroom, Ira Fulton Auditorium, holds 150 seats. And yet our faculty, our students don't mind big class anymore because the classroom is such a well-designed with the natural light coming in. So we want to thank all of our support for building this amazing facility. So this year I'm pleased to feature Dr. Ann Masser-George, and she'll talk about her research on autism and young children. But let me say a few words about Dr. Masser-George. She's an associate professor and associate extension specialist in family studies and human development in the Norton School. And she received her PhD from UCLA in 1991. And for the past 20 years, she has built a strong research and outreach program in the area of early childhood, particularly focusing on at-risk children and children with disabilities. Last year, we recruited that means we stole her from UC Davis. And many of you know Dr. Stephen Russell. When we recruited him from UC Davis, everybody from UC Davis wanted to come to our program. So we are successful at getting her from UC Davis because not only she's a strong researcher and academician, but also we really have a strategic plan to build an early childhood program in the Norton School because the state of Arizona, believe it or not, it has many, many young children. In fact, the average age of our state is young, unlike what people think we have more retired people. So we need to build a strong early childhood program, and Anne's been brought to help us build that program so that we can make a positive impact statewide and nationally. And all of us know how important the early years of our children's life is for them, for their lifetime, but we got to do a better job of translating our research into practice. That means whether it's parenting or policy making or everything else. So we're very, very pleased to have her with us. And with that in mind, she's going to talk about, under the title of Early Signs and Early Intervention in Autism, what parents need to know. A lot of people wanted to come but couldn't make it, so we're taping it. We're going to make it available. So if you want to have access to her talk, just let us know. We'll make it available. So without further ado, please welcome Dr. Ann Masser-George.
Thank you. A mic. Thank you very much for that kind introduction, and I'm very happy to be here. So I'm going to be talking about early signs and early intervention in autism, what parents need to know, but it's actually what all of us need to know. So I'm going to start with an overview of early signs of autism. I'll be talking about the role of parents, and then also talking about some approaches to early intervention. So let's start with what is autism. Almost all of us know somebody who has autism, has a family member with autism, and has heard of autism. But generally the term has been used to describe a group of very complex brain disorders known as pervasive developmental disorders, or PDD. And the American Psychiatric Association's Diagnostic and Statistical Manual, also known as the DSM-IV, is the main diagnostic reference, sort of the diagnostic Bible that we use to make the diagnoses of autism in the mental health profession. The diagnosis requires, and I'll talk about this a little bit, at least 6 developmental and behavioral characteristics that are observed and present before the age of 3. So this is basically what it looks like. So you have the basic pervasive developmental disorders, autistic disorder, and then these others are also considered to be the spectrum of disorders. There are 3 primary areas when we think about autism that we look at for diagnostic criteria. So the first one is qualitative impairments in social interaction. The second one is qualitative impairments in communication. And the third is sort of this restricted and repetitive behaviors and interests. So I've listed some of the things that we look at. So in social relatedness, for example, you see limited eye contact. That's one that many people are familiar with. Also limited facial expressions, and oftentimes either a decrease or no response to name. For kids who are a little bit older, they have few or no friends, little interest in sharing either objects or activities with others, and what we call limited social emotional reciprocity, which means engaging with other people. We also see communication delays, either no language or limited language or unusual language and unusual prosody or intonation, and limited use of gesture. So these are things when we think about early signs, which I'll be talking about, are things that we want to be thinking about. And again, limited play and imitation, very, very important skills for language. In terms of the repetitive behaviors or restricted interests, oftentimes we see children who are interested in just looking at aluminum foil for 4 hours or watching leaves blow in the wind. They have highly focused interests. Some kids are memorized, they know every train station and in the country and what time it leaves from what city. Those kinds of very highly focused interests, which, or I actually worked with a child who was only interested in sprinkler systems, and his parents couldn't understand why other preschoolers weren't interested in talking to him, because that's the only thing he wanted to talk about. So those are some of the things, and again, some rituals around sameness and not being flexible about things changing. Those are some of the things examples of these diagnostic criteria. So as I mentioned, again, it's more complicated, so I'm going to simplify it, but there are so many symptoms that you have to have, for example, 2 from the social domain, 1 from the communication domain, and at least 1 from the restricted behavior. So you have to have at least 6 of these 12 symptoms, and then also delays in one of the symptoms listed below prior to age 3. So it seems very easy when you look at the criteria, but there's a lot of clinical judgment that goes into actually making a diagnosis of autism. What I'd like to do now is focus on some of the social symptoms, because I'm going to be talking about very young signs in early signs in children who are very young, I should say, and wanted to focus on some of those things that we can see very early. So again, failure to use nonverbal behaviors to regulate social interaction. So what we see in very young children is that very limited eye gaze as a risk, not any use of gestures or very few gestures, and not using pointing or showing of objects, lack of sharing interest and attention with others, and again, this limited social and emotional reciprocity. We can see these things very, very young. It was suggested in the 1970s. It's 1.5 times higher than thought in the 80s and 90s. And some of this, there have been many proposed explanations, some of which have been better identification. So we do have also many more sensitive diagnostic tools, including the Autism Diagnostic Observation Scales, which is considered to be a gold standard for diagnosing children with autism. We also have broader classification systems, so children who may have been just considered to be quirky or unusual might now be considered to be on the spectrum. And then there are also issues around environmental factors as having some contributing factors to the increase in autism. So I'm going to show you now just some of the rates past and present. So if you look at 1985, 1 in 2,500 children were diagnosed with autism. In 2000, 1 in 500. In 2004, 1 in 66. In 2007, 1 in 150. And just recently reported by the CDC in 2011, the reports of prevalence now are 1 in 110. Very, very dramatic. So the fact that you might be hearing more about autism, it's not just because because it's out there. It's definitely what many people believe is an epidemic proportion. Now let's just talk a little bit about the basics of autism. We do know the onset is during the first 3 years of life. It is a chronic lifelong course. There's no cure for autism, although with early intervention, many children can have subclinical features, meaning that with very, very intensive early interventions, you might not actually be able to see the symptomatology of autism. The male to female ratio is 4 to 1, which meaning there are four times as more likely boys to have autism than girls. There is an underlying neurological dysfunction, as well as genetic factors, which I'll talk a little bit about, and a spectrum of severity. So there are some children who have many more difficulties with some of the symptoms that I mentioned earlier, and some who have fewer, some who respond to intervention much more quickly than others. Those are the kinds of things that we're trying to figure out in our research. Autism is a developmental disorder, and this is very important. In order to really understand and accurately diagnose autism, it's very, very important to have significant understanding and knowledge of typical development in social areas, communication, cognitive and play skills. So it's hard to know what's not typical if you don't really understand what is typical. And again, these developmental profiles will also help us understand the ways in which we can then proceed in intervention. Autism is also a neurodevelopmental disorder with a biological basis. There are many genetic factors involved as well. So, for example, we do know the recurrence rates for autism after the birth of one child with the disorder. Early reports were that it was 3 to 6%, and most recently in 2011, I'll talk about that report, a recent finding, it's 18.7%. And the concordance rate for autism in monozygotic or identical twins is 60% and up to 90% when you think of more broader phenotype, or what we call other kinds of things that are going on, not necessarily autism, but social communication, difficulties in language skills that are delayed. And there are also many genome and molecular genetic projects and studies that are going on to investigate the kinds of things that are contributing. For example, there are some recent studies looking at differences in maternal antibodies in children who have autism and those who do not. The broader phenotype factors are basically factors that are related to autism, but not necessarily considered autism. So what we do see is in many children who have siblings with autism, they may have attention deficit disorder with hyperactivity, anxiety, social shyness, language disorders, those kinds of things. And we also know that there are organic brain dysfunctions. We know that now based on some of the technology that is available to us in terms of looking at functional imaging, structural imaging, where we do know that children with autism have increased head circumferences, increases in brain volume, and brain region deficits. So let's talk a little bit about the neurobiology of autism in terms of some structural brain changes. We do know that the overall brain size is greater in children with autism. There's an abnormally rapid growth in infancy, which is, some of you may have seen that the head circumference sizes of children with autism are generally larger. That doesn't mean if you have a large head, you have autism, but it's just one of the risk factors. And in the cerebellum, we know that the posterior vermis is smaller. This is an area that actually has to do with motion and body in space. And the amygdala is another part of the brain that where there are reports of larger growth in the latter part of the first year. The amygdala is what helps us process faces and emotion, and is very, very important for this joint attention that I'll be talking about, which is that back and forth and social reciprocity. There are also brain changes in the function of brain. So we see less activation in the amygdala and the fusiform gyrus, frontal cortex. And these are changes and differences that can be seen when someone is actually in a scanner and they're actually performing tasks. We can see where the brain lights up and where it doesn't. And there's less functional coordination among the regions of the brain. So these types of studies are generally done with children who can actually stay in a scanner. So they're generally kids who are they're not infants or toddlers. In terms of the genetics of autism, which I just talked about briefly, we do know that in terms of multiplex families, these are families who have more than one child with autism, that the recurrence rate is somewhere between 10 and 20%, and they then are at risk for having these broader autism phenotype disorders. So again, we do know that there are genes also involved. So we know that there are possibly 3 to 10 genes that are estimated to be related in some way to autism. So there has been work on the chromosome 5 and 7 and 15, looking at ways in which these particular genes and chromosomes are impacted, as well as environmental contributions. So there have been some studies done recently by epidemiologists and immunologists looking at environmental factors and places that people live near ports or farmland where there are risk factors for pesticides and other kinds of environmental hazards, or that may actually impact or turn on a gene for autism. So those are more recent kinds of studies that are ongoing now. So I do want to talk a little bit about the infant sibling piece, because this is certainly one where there's been a lot of work done recently looking at siblings of children with autism, and then also looking at siblings of children with typical development. So these are studies that are going on across the United States now, so that we can see what are the risk factors very early on following children from 6 months, infants, 12, 18, 24, 36, and then following them at 7 years of age. So let me just show you a little bit about some of the differences in developmental outcomes at 36 months. So we can see here that the at-risk siblings, so these are the young babies who have older siblings with autism, 17% of them were diagnosed with autism, 25% with other delays, 58% had no concerns, but overall 42% were affected in some way. When you look at the controls, you can see only 15%. So there is something going on with siblings of young children with autism. And what we do know that is there are other things that are overlaid onto their development. And in terms of looking at the recurrence rate of autism, it is much higher than expected. So this is the study that I briefly mentioned earlier. There's a study that has just come out in, I believe, August of 2011, where the recurrence rates are now, as I mentioned earlier, 18.7% of infants with at least one older sibling with autism, which is very, very high. The 2 strongest predictors of that are gender, so that is boys are more likely to have autism in a recurrence in a family, and also the number of affected older siblings. So that is, if you have 2 or more, you're more likely to have another child with autism. So in terms of thinking about all of this, are siblings of children with autism at higher risk for are siblings of children with autism at higher risk for autism? Yes, especially males. And are there other developmental problems that we need to be thinking about? Yes, especially language delays. And how early are the first signs evidenced? And we can actually see signs in very young infants, 6 to 12 months of age. And what are those signs? Those signs are poor responding to name, decreasing eye contact, limited or decreased smiling, and very limited or decreased or absent social interest. So we do know that autism emerges over time. Signs of autism are not usually present at birth in many children, but losing skills is much more common than we previously thought, which is something else I'll be touching on later, why it's so important to do this developmental surveillance, because children might look very typical at 6 months, atypical at 12 months, typical at 18 months, and then not look so good at 24 months. So as we're learning more about the trajectory of autism, we do know that it doesn't always follow a linear line. Regression, that is losing skills, is often subtle, gradual, difficult to observe in real time, and sometimes difficult to capture by parent report. So what we do know is the American Academy of Pediatrics has put forth some clinical implications for this, and that is that infants at risk for autism should be offered intervention for symptoms rather than waiting for an effective diagnosis. As soon as you see something's wrong, intervene. Something's not developing, you want to intervene, because development of treatments for infants not only is it an urgent priority, but we do know that these interventions make a very big difference. So if we can do screening several times during the first several years of life, we might also be able to then continue to look for these markers that identify risk before we see these behavioral symptoms that I mentioned earlier. So again, when we talk about autism being identified early, we do know that the most common symptom reported by parents is delayed speech or abnormal speech development. And oftentimes we see these abnormalities occurring in the first or second year of life, even before language is occurring, again with the diminished eye contact, not referencing things that are going on, whether it's around an object or an activity, limited or no imitation of sounds or words, not orienting to their name. Oftentimes parents will say, it seems as if my child is deaf, and not really sharing attention and affect. So again, these are things that if we pay attention to parents and the things that they're talking about, again, this early recognition can provide us with a lot of early intervention markers that we want to be focused on in searching for the autism etiology. So the typical age of autism diagnosis is somewhere between 34 and 61 months, so somewhere between 3 and 5 years of age. But the mean age of parents' first concerns is around 18 to 19 months of age. That's the mean age. And 30 to 50% of parents report concerns before the first birthday. So you can see there's a big discrepancy between what parents report and when the diagnosis or intervention occurs. So for example, Stanley Greenspan, who's done a lot of work in this area, I'm using a quote that he talked about. Most mommies and daddies tell me, I thought there was a problem at 14 or 15 months, and they told me, let's wait and see, because sometimes kids grow out of it. Well, that's not a good answer. We've got to make this distinction between less important problems, where we can wait and see, from core problems, which involve a lack of reciprocity and a lack of getting to know your world. For these core problems, we have to act on it yesterday. We can't wait 9 months. We can't wait 2 months. And that's basically how parents often feel once they know something's wrong. Now, we do know the onset patterns of autism varies. So there can be differences in development in the first year of life. Oftentimes there can be a developmental plateau, which means that children start to develop these early developmental milestones, but then it's followed by a failure to progress. So they might start to engage in some social games, but then it just stops. Other children have a regression, which is they have achievement of early milestones and even language, and then it's followed by just a complete loss of skills. So what I'm going to do now is show you an example of a typically developing 6-month-old and then one who looks, it's what we think autism is going to look like very early on. So this is 6-month-old, and just what I want you to do is watch his eye contact and his affect.
Here it comes. Here it comes.
Watch how he's looking up at his mom as well.
Look, it's a donkey like Lily.
The other thing I want to show you and why it's so important to do this surveillance is this is just to show you a symptom onset of social skills, but primarily focused on gaze fixation. These are typically developing children from 6 to 36 months, and these are children with autism. And you can see at 6 months that they're very close together. In fact, some of the autism has more gaze here, but it's not statistically different. But you can see the dramatic difference in autism where their social skills and gaze goes way down, where the typically developing group stays up high. So again, these are very important indicators for surveillance in development so we can see what's happening. What are the early signs of autism? Again, by 6 months, a failure to look at faces, smiling at others, limited cooing, as you just saw in that 6-month-old who did virtually none of those things. By 12 months of age, not responding to their name, not playing social games, or displaying what we call a bright affect. And by 18 months, not pointing and showing, using single words, gestures, not imitating, or showing interest in other children. So these are all big red flags. If any of these things are happening at children at this age, there should be an intervention conducted. We do know that, again, the American Academy of Pediatrics recommends these early signs being looked at very early in their routine surveillance when they come in for developmental, their developmental visits. And then again, this universal screening for autism, what we what is recommended is twice a year by the second birthday for all of the reasons that I just mentioned. I'm not saying that these things often happen. This is what is recommended. Now, again, the best practice for screening for autism, all of those things that I just mentioned, because we know that it can be identified early, and we also know that parents are really the experts in regarding their children. Many of them have gut-level feelings that something's not quite right. So really eliciting and valuing their concerns is really imperative as well. There are lots of screening tools. I'm going to focus on just one that could be used in a doctor's office. There have been some studies also done looking at this already. It's a 23-item checklist that is designed as a screener for autism. It's also in Spanish. It's a yes/no. Parents can fill it out, or the physicians can ask them these questions. It takes basically 5 minutes. And here are some sample questions where you just ask, does your child look at your face to check your reaction when faced with something unfamiliar? Does your child bring objects to you? Does he or she ever use their index finger to point? Responding to name, things that we've already talked about. And then yes or no, you get a clear indication whether or not there is some kind of risk. So again, looking at early intervention guidelines allows us to get children into autism intervention programs as soon as there is some risk considered, as soon as even there's a diagnosis is being considered and maybe not even implemented yet. And again, what we want is that there's this active engagement with the parents as well in intensive instructional programming, so there's repeated and planned opportunities and mechanisms for really thinking about ongoing program evaluation. And these are all things that are recommended by the National Research Council on Educating Children with Autism. So what I'm going to show you now is a video that was actually made at the Mind Institute, where I did come from prior to coming to the University of Arizona, and the dramatic changes in that child that we see in many young children who have intensive early intervention. Now, you did see the parent was also very involved in that intervention as well. And what I do want to now talk about are the role of families in intervention and how important it is. Again, what we focus on in these interventions is really helping parents learn to apply skills to change their child's behavior, to use effective teaching methods, and to access information from a range of appropriate services that they might need. So it's critically important that parents be involved in interventions. This parent-mediated interventions are now considered to be standard and evidence-based for many of the intervention programs that are now available. What I do want to mention is there is a 100-day kit for parents. You can just Google first 100-day kit for autism, and this is a kit that was developed by Autism Speaks. And I just have screenshots of a couple of pages here. It's an 81-page PDF that has all sorts of information about autism, what parents need to do, what kinds of services might be available, how to decide what kind of intervention might be the best intervention for your particular child, and lots of information as well as then what to do for the first 100 days, very specifically. It's been widely used and was also, both parents and professionals were involved in constructing this. So I highly recommend this, not only for parents but for professionals as well. So again, when we talk about these relationship-based interventions, again, when you're thinking about intervention with very, very young children, their first teacher is their parent. So it makes sense that we would be using parents as facilitators, as co-constructors of the intervention, and collaborators in the intervention. We do know that these kinds of interventions have demonstrated to improve not only the outcomes for the child, but also the quality of the interaction for both the parent and the child as well. So basically what we are hoping to do in these interventions, and I primarily use mothers here, not because fathers aren't important, but most of the work in very early intervention is done with mothers, is providing this maternal support for creating responsive interactions and demonstrating the kinds of strategies that focus on helping mothers to become sensitive and responsive in these joint attention interactions. When you have a child who's not responding, ever, or very limited day after day after day, it's very difficult for them to know what it is they need to do, or how is it that they could or should engage their child in an interaction. So what we do is provide a lot of developmental and relational guidance in the interactions. So what I'm going to show you now is one such thing. So this is a parent who's been working at home and working with a clinician, and then you'll see how their working are really important in terms of looking at development as an interpersonal process. So, and we know that the quality of these relationships mediate the development. So it's very, very important to have the families not only involved in the intervention, but directing the intervention. So I've talked about some of these already, but we do know that there are many techniques and practices that can be used. I've listed some here, but very focused strategies for helping parents engage in turn-taking and using positive affect and elaborating activities as some examples. So the goal is to then have them used in settings all across the day. So perhaps starting obviously with parents, but then in interactions with others, with their peers, and in preschool, so that it becomes generalized across all of the settings that the child is involved in. So there are lots of early intervention parent-mediated approaches. There's the Early Start Denver model. These are by no stretch of the imagination all of them, but I'm just mentioning some. The Early Start Infant Study. There is the Floor Time Developmental Individual Difference Relationship Model, a relationship development intervention, and then there are joint attention interventions. So there are lots of different interventions that are out there. Some of them overlap in terms of the ways in which they approach intervention, but all of them use parents as a primary pivot in the intervention. I'm going to be talking about joint attention interventions in a few minutes, but what I do want to show you in terms of using the parent, this just shows you early on, these are 8 parents, and these are the sessions. This shows you the baseline, so basically when the parents are just starting to learn a joint attention activity. Here's the treatment, and these are all the parents, and then follow-up. So again, 3 months later, parents are still using these kinds of strategies. So we know, based on some studies that have already been done, that parents are very, very good at not only developing a routine and a dance with their children, and figuring out what the synchrony is in the interaction, but also able to maintain the use of these evidence-based strategies. So what I'm going to do now is talk about joint attention intervention. We do know that one of the very early experiences is the development of joint attention. Again, it involves this triadic attention between self and others. I'll show you just in a few minutes a video. And it's also a skill that is a hallmark deficit in very young children with autism. So this briefly is it's a joint attention intervention that was designed for toddlers and preschoolers who had recently been diagnosed with autism. So either they had just been diagnosed or within 6 months, and it's a 16-week intervention. And 16 weeks doesn't seem like a long time, but when you have parent-child interventions that are conducted in a home-based context, in structured play interactions. So we provided them with toys. They had some training. They did come into the lab so we could actually see how things were going. We had the parents videotape once a week, and they were also involved in collecting lots of other things as well, which I won't have time to talk about now. We looked at lots of things, including early social communication skills. So again, we looked at their initiating joint attention, responding, and their social interaction skills. And we also looked at eye tracking, which is a more recent paradigm that some labs across the country, probably not more than 20 actually, are using so we can actually track children's their eye movements, their gaze, and their fixation on a computer, which actually it calibrates the pupil of their eye. So it's a built-in camera, and it actually remembers them. So when they come back again, it actually will calibrate their eyes and has all of the data stored. And it basically is like sitting at a computer, but it's a very expensive one. So this is what it looks like. So we had different scenarios, and this shows you, so the pink dot here is how long they were looking, and this is a child with autism, so they're not looking at either of the characters, and this shows you their gaze shifts. So we can also look, I don't know how well you can see this, but there are numbers here, so we can see where the child looked first, second, third, and actually be able to see whether or not they're looking in places they should be looking. Lots of children with autism will be looking, and it looks as if they're looking at you, but in fact, we know they're looking at the background or they're looking at the girl's bracelet rather than actually looking at the eyes or getting information. So what I'm going to show you very quickly is hotspot, and a hotspot is where they're looking. So this is a child with autism. So the red is considered the hot, so the longer they're looking in these places. And this is a child with typical development, so you see that they're looking more at the interaction between the two characters. What I'm going to do now is show you very quickly the child's behaviors in terms of their joint attention. They did increase. The maternal sensitivity that we also looked at increased as well. The reciprocity went down a little bit, but we think it's because the mothers were taking so many turns in the beginning that it went down a little, and I don't think that really reflects it. But we saw maternal sensitivity was a really big change in their behaviors. And also for the children, their use of imitation and their words produced changed quite a bit as well after the intervention. And you probably can't see this, but so you'll have to just trust me. That pre-intervention, this is just one frame where actually the cat is talking, but this particular child is looking here at her dress and at some decoration that was on the bed skirt and at his bow tie, and after the intervention looking right at the cat who was talking. So again, this just gives you some indication of how much some behaviors can change in very young children with autism with a pretty short-term intervention of 16 weeks. So I'd like to conclude with saying that early identification, in terms of understanding that we need to respond to symptoms and signs of autism before the diagnosis, because there are so many things that are happening even before that we can intervene and make a huge difference in terms of their developmental outcomes. And also in terms of relationship-focused interventions, this general developmental approach to developmental intervention encourages parents to use responsive interactive strategies, which we know are so important to mitigate the social deficits in the reciprocity and social relatedness and communication skills, as well as play skills. And using and understanding the parent's experience is a way to, in response to the emergent symptomatology, does allow us to provide a gateway for these social communication activities in intervention contexts. And what was called early intervention, I would like to say now that early intervention is now the new early intervention. And I want to leave you with this. So there is in the 100-day kit at the toward the end, there's someone who wrote from 10 things every child, it's from 10 things every child with autism wishes you knew. And this is the 10th one. And it says, and finally 3 words, patience, patience, patience. Work to view my autism as a different ability rather than a disability. Look past what you may see as limitations and see the gifts autism has given me. It may be true that I'm not good at eye contact or conversation, but have you noticed that I don't lie, cheat at games, tattle on my classmates, or pass judgment on other people? Also true that I probably won't be the next Michael Jordan, but with my attention to fine detail and capacity for extraordinary focus, I might be the next Einstein, or Mozart, or Van Gogh. They had autism too. Thank you very much.
Thank you, Anne. Because of the luncheon, we may have maybe question time for one.
Oh, okay. Yes.
Yes, I have a brother that was diagnosed as an adolescent with being schizophrenic, and the diagnosis has recently been changed when he's in his early 60s to Asperger's.
Yes, and actually that's very common.
And the thing about it is, though, I've gone to some autism programs in Phoenix, and everything's on childhood autism. But what happens to all these children as they become adults? I don't hear anything about that.
Right. Well, there actually is a body of research that is being done with adolescents and adults with autism. It's not as large as you would expect because funding actually makes a big difference in terms of what people end up studying. And so a lot of funding at the moment is for very early development. But there has recently been some changes at NIH because a lot of parents who have children who are adolescents or adults with autism want to know where the focus is for them. So there actually has been a recent change in studying those children. And
funding for programs.
that's right. Well, the funding for programs comes from people studying what programs work. And so I think that will be changing because as you're right, there are many more people now who have autism, who are adolescents and young adults, and adults in general. And there does need to be programs for these individuals because they have many skills that need to be highlighted.
Are you already prepared? Well, do know that the doctor and messengers will be joining us for lunch, and if you have any questions, please come and talk to her. And just send us the email. We're going to tape this one so we can make it available for your friends and family members. Why don't we join us for giving her an applause?
Thank you.
Thank you very much, and if you're registered for lunch, and lunch should be served.